Welcome Hi, and welcome everyone. Sorry that we are a few minutes late. As you know, in this virtual world, sometimes there are some unforeseen circumstances, so we certainly appreciate your patience with us. Welcome to the 2021 STI Treatment Guidelines webinar, presented to you by the National Network of STD Clinical Prevention Training Centers. I'm your host, Destiny Kelly, coordinator of the NNPTC National Coordination Center. If you have technical issues, please use the chat to reach out to our producer. This webinar is being recorded, and you will have access to the PowerPoint within 72 hours after the webinar. This webinar includes approximately 60 minutes of didactic presentation and approximately 30 minutes of question and answer session. Please hold all your questions till the end of the presentation. And due to the size of this webinar, we will use the Q&A function on your Zoom toolbar, not the chat function. The NNPTC is made up of 8 regional PTCs and 2 national centers. We are CDC funded to train clinicians in the diagnostic, treatment, and prevention of STIs. Our National STD Curriculum Center is currently reviewing and updating all content to align with the new STI treatment guidelines and will launch a 2nd edition, so stay tuned. The STD Clinical Consultation Network is a free online system where clinicians can submit complex STI questions, and an NNPTC expert will answer that in 1 to 5 business days. NACCHO and CDC's Division of STD Prevention are collecting information on sexually transmitted disease clinics. NACCHO will develop a searchable tool of existing STD clinics and what services they provide. Help us complete the registry by saving the link in the chat and filling it out after the webinar. Continuing education is available through the CDC Training and Education online system. This is a separate system from your registration. Instructions for completing evaluation and obtaining CE will be emailed to you after the webinar. The deadline for obtaining CE for this webinar is October 15th, 2021. So now we're going to go over a few goals of today. We want to share updates included in the 2021 STI treatment guidelines, discuss the rationale for these updates, and align clinical practice with updated guidelines. Our NNPTC expert STI panel from across the country today includes Dr. Candice McNeil from the Southeast PTC, Dr. Joesph Cherabie with the St. Louis PTC, and Dr. Hilary Reno, also with the St. Louis PTC. Our Q&A facilitator is Allison Finkenbinder, who is a women's health nurse practitioner with the Denver PTC. And these are our faculty disclosures. I will now turn it over to Dr. Candice McNeil with the Southeast PTC.
Thank you, Destiny. So it's great to be with you all here today. Of course, over the course of today's presentation, we will be reviewing the current STI treatment guidelines. These guidelines for the treatment of persons who have or are at risk for sexually transmitted infections were developed by the CDC in consultation with a group of experts in Georgia in 2019. And the guidelines were updated to include current evidence-based diagnostic management and treatment recommendations. They are the source of clinical guidance for managing sexually transmitted infections, and they also provide you really cool tools and resources to support STI care and prevention. So a really important thing that you probably noticed up front is that our name has changed. We have gone from STD to STI, STD being a disease arising from infection through sexual contact, and STI, a pathogen that causes an infection through sexual contact. There will also be talks about antimicrobial stewardship, the pharmacodynamics and pharmacodynamics, resistance recommendations, and also updated guidance on gonorrhea, chlamydia, trichomonas, prevention tips, and then screening optimization as well. So we are so excited to have you here today. let's get started. So first of all, STIs are costly, and you probably know this as a practicing STI physician. And we're talking about 1.1 billion direct costs are attributable to common preventable infections such as chlamydia, gonorrhea, and syphilis. There is a considerable burden in our youth as well as women. So besides being costly, we also have to take into account that these diseases are challenges for wellness for millions of people across the US. Surveillance data from 2019, next slide, highlight, next slide. Sorry. Surveillance data from 2019 highlight the increased rates of STIs across the country. Alarmingly, there have been an increase in the number of syphilis and congenital syphilis cases, and there have also been increases in chlamydia and gonorrhea since 2015. Next slide. So we're going to be talking about gonorrhea and chlamydia now. Next slide. So STI screening is essential, a very essential component to risk assessment, and allows for us to detect asymptomatic disease and disrupt the transmission cycle. So for females less than the age of 25, we're talking about routine screening annually, and then also increased screening based on risk. And what are we talking about here? We're talking about individuals who report new partners, multiple concurrent partners, sex in exchange for money or resources. And then there are other groups where we consider screening based on risk. And these include men who have sex with men and individuals on PrEP, where we're screening as frequently as Q 3 to 6 months in this population. Now, you might want to identify additional populations for screening based on your local prevalence. And you also need to take into account where to screen. So anatomically, where you screen depends on exposure reported, depends on behaviors reported to you. And you'll see at multiple points throughout the guidelines, they talk about this shared decision-making process. So what is that? That's when you, the provider, along with the patient, talk about their risk and the available evidence and come up with the best plan for them. So here we go. Screening, super important. We should definitely get it done. And we want to rescreen anybody who has an STI within 3 months and more frequently in particular populations. Next slide. Because the goal is that we want to avoid the manifestations of symptomatic disease, including sequelae. And you can see here represented on this slide, images of infections at glandular and mucosal sites, the eye, the pharynx, urethra, proctitis, as well as cervicitis represented here, upper tract disease, including PID and epididymitis, and then also disseminated disease as well. Next slide. And STIs are really getting more challenging to treat, in some instances due to the emergence of resistance. Now, you'll see represented here on this data from the 1980s going on into present time. And combination therapy has really been therapy management that we have supported for quite some time. It's been around since the 80s, when we have looked at treatments for gonorrhea and chlamydia at the same time. Now, our guidelines have evolved, looking at patterns of resistance over time to account for changes. In 2007, fluoroquinolones were demoted, and cephalosporins were really the only class we had to rely on for gonorrhea treatment. Dual therapy with ceftriaxone or cefixime and azithromycin or doxycycline came into favor in 2010, and subsequently changed to ceftriaxone and azithromycin as efforts increased to try to preserve cephalosporins as a class. That leads us to 2019, where we were looking at about 45% susceptibility to all the antibiotics that are used to treat gonorrhea. So really, we were in dire straits. Next slide. So why did we change these guidelines? So we changed these guidelines because we really need to improve antimicrobial stewardship. We had to look at pharmacokinetic and pharmacodynamic considerations. We also need to look at changes in azithromycin susceptibility. Next slide. So on the stewardship standpoint, we're talking about a major public health concern, right? Drug-resistant gonorrhea is an urgent threat. We need to minimize antibiotic exposures unless the risks outweigh the benefits. And we've noticed some concerns regarding the microbiome, specifically in pediatric populations receiving azithromycin, where we've seen increased determinants of macrolide resistant and even non-macrolide resistance. And then we've also seen macrolide resistance in nasopharyngeal carriage of strep pneumoniae, for instance. Further resistance trends have been noticed with enteric pathogens, as well as STIs such as Mycoplasma genitalium and others. So dual risk versus benefit, dual therapy, risk versus benefit really need to take into account when looking at the guidelines. Next slide. So looking at Mycoplasma genitalia, for instance, you will see that across the United States, there are representative groups of resistance to macrolides on the manner of 44 to 90%. And we know in instances where we have macrolide resistance, treatment failure can occur. Next slide. That leads us to enteric pathogens. And in looking at Campylobacter and Shigella, for instance, we've noticed trends in azithromycin resistance over time. And you can see represented here data for Shigella as well as Campylobacter. And particularly in Shigella, I should mention from 2013 and beyond, we were seeing those trends very pronounced, the implications for which they go beyond the treatment of classic enteric illness. Next slide. To sexually transmitted enteric pathogens. Yes, we have gotten there. And we should consider these infections when we're seeing outbreaks of gastrointestinal illness in social and sexual networks of men who have sex with men. Specific syndromes to consider include proctitis, and that's when we have inflammation at the level of the rectum, along with symptoms of diarrhea, cramps, and other such things, and inflammation of the colonic mucosa, as well as enteritis, which is the absence of proctitis or proctocolitis and the presence of diarrhea and abdominal cramps. So we really need to keep this in mind. We've seen resistance patterns for Campylobacter and Shigella in these populations, along with multiple other drugs. And then also, we've also seen concurrent STIs in this population, including HIV and syphilis, chlamydia and gonorrhea, as well as concurrent substance abuse, meaning that this is also a population where we would want to consider doing really enhanced prevention counseling. Next slide. So that brings us to azithromycin. And as I mentioned, we've seen some concerning trends here. Specifically, you'll note on this graph, there are changes in ceftriaxone susceptibility. Going from about 2013, you see some variable levels occurring. But azithromycin is definitely more pronounced here on this graph, and you will see that progressive increase in the minimal inhibitory concentration, or the lowest concentration that's needed for azithromycin to treat infections over time between 2012 and 2019. Next slide. So accounting for these elevated MICs, and in order to preserve classes of antibiotics that we have available to us, we know that we need to be very thoughtful about our dosing of ceftriaxone. So using modeling studies and also mirroring models, we have been able to work through a dose that is appropriate in terms of the duration of the drug above the MIC. And that dose appears to be 500 milligrams, which would exceed the duration needed for resistant infections or presumed resistant infections at the pharynx. And we still need to take into account that there is some uncertainty at the pharynx. We just don't really have great data there. Next slide. So what is it about the pharynx? Well, the pharynx is a site where we often have asymptomatic infections. And if you don't screen there, you will not find that infection. It's also been a site globally where most of the reported ceftriaxone-based regimen failures have involved that site. It can be difficult to eradicate as well, infections at the pharyngeal site. And there are few regimens that can achieve that greater than 90% cure rate that we thrive for. So because of this, we now recommend that we do a test of cure in the range of 7 to 14 days post-treatment for pharyngeal gonorrhea infection. And I would recommend that you actually consider the latter end of that range, that 14 days, because we know that there is potential to detect remnant nucleic acids, which may not necessarily represent a live infection, going on at that pharyngeal site. Next slide. So to recap, the current recommendation includes ceftriaxone 500 milligrams IM times 1 for individuals who are less than 150 kilograms. And then for those greater than 150 kilograms, we're talking about 1 gram. And you want to co-partner that with doxycycline if you have not ruled out chlamydial infections or if chlamydial infections are of a concern. This, of course, will not be the dosing if we're considering individuals who are pregnant. In that case, we would use azithromycin as the preferred co-regimen. And dual therapy is no longer universally recommended for the treatment of gonorrhea. Next slide. So new in the guidelines is also this reference to alternative gonorrhea treatments. And you will see that the dosing of cefixime has increased to now 800 milligrams as the recommended dose if you have to treat gonorrhea and you do not have access to ceftriaxone. Then this could be something you use. And again, co-partnered with your doxycycline. And this doxycycline, again, would be used to treat chlamydial infections if suspected or confirmed. Now, this cefixime, it is great. It's an oral regimen, but I want you to keep in mind that it does not provide really high and sustained levels that are bactericidal in the blood. And this is particularly concerning for infections involving the pharynx. So if you have a pharyngeal infections, please use caution and go with the preferred recommendation, which would be ceftriaxone. Now, allergy. For people who are allergic to cephalosporin-based regimens, we have the option of using gentamicin, 240 milligrams IM, along with azithromycin, 2 grams PO. I should mention here that I would encourage you, before moving to that, to do a really careful allergy history, accounting for whether this is an IgE-mediated reaction, because you want to really make sure, again, because the tried and true way to treat a gonorrhea infection of the pharynx is going to be using our cephalosporin-based regimen, where we know we have great efficacy. The studies with gentamicin and azithromycin, at least one of them has not been powered to look at infections of the rectal and pharyngeal sites. And the other one, we really didn't see great performance at non-genital sites, including about 80% at the pharynx and 90% cure rate at the rectum. So again, go with cephalosporins all the way. Ceftriaxone is the way to go, unless you are in a corner and you have to, think of another regimen. Next slide. So other changes to note to the gonorrhea treatment guidelines include that every place in the guideline where you see that there is the prior dosing of ceftriaxone, you're going to replace that with the new recommendation of 500 milligrams of ceftriaxone, and if greater than 150 kilograms, that 1 gram dosing. So this is going to occur with urethritis, cervicitis, pelvic inflammatory disease, proctitis, and epididymitis. And again, dual therapy is not recommended. Next slide. Cervicitis. So 2 major diagnostic criteria for cervicitis, and these include that mucopurulent endocervical exudate, as represented on the mucopus on the slide on the right. And then there is the contact and endocervical bleeding. In terms of diagnostics, we're looking for chlamydia, gonorrhea, trichomonas, HSV, Mycoplasma genitalium, and non-infectious etiologies such as douching, irritants, and other things, dysplasia can come into play, so keep that in mind. In persistent infections, think about whether you might have abnormalities of vaginal flora, and then think about our friend Mycoplasma genitalium. Treatment, we already discussed this, and there's no support to treat in cases where you don't have a diagnosed infection. Next slide, proctitis. Proctitis is a syndrome which we do encounter somewhat often in the STD world. And one thing to keep in mind in terms of diagnostics, anoscopy is now one of the tools you want to consider in using, particularly when you're trying to determine what the cause of the infection is. You're going to think about looking for your common STIs, gonorrhea and chlamydia, and also do testing for those things as well as HIV and syphilis screening. And if you are noticing that you have blood, ulcers, and pain with defecation as a complaint, then you want to go and also concurrently treat with antivirals, because in that case, you would be concerned about the possibility of HSV, which will be discussed later in our slides. LGV treatment, that will be with doxycycline, 100 milligrams BID for 3 weeks. Again, if you have those complaints of blood, ulcers, and pain, again, we want to talk about making sure that our treatment is of appropriate duration. And in this case, this would be using our doxycycline regimen for 3 weeks. As a reminder, next slide, LGV is an infection of the L1 through L3 serovars of chlamydia. We often have to make this diagnosis based on clinical suspicion because we don't have great diagnostics available to us. And so keep this in mind when you're looking at the clinical scenario I just mentioned. Optimal duration, again, would be with the 21 days, but there have been some small studies of note where they've used shorter regimens as listed here. But in going with the tried and true recommendation, we're going to go with the 21 days of doxycycline as the recommended treatment. Next slide. Epididymitis. Epididymitis is the clinical syndrome characterized by pain, swelling, and inflammation of the epididymis that lasts for less than 6 weeks if we're talking about acute cases. And the thing that's changed in the most recent version of the guidelines is that it's really important to take a risk assessment. We're not just going on age. We know that risk is not static. And so you can see represented here the various regimens that would be used when we're talking about infections where we're concerned for STIs exclusively versus STIs and enteric pathogens versus enteric pathogens alone. Next slide. Cephalosporin treatment failure is something that we do have to consider, especially in the era that we're in. And so when we have individuals that have failed to respond to treatment within that 3 to 5 day window, then we need to consider, especially if there have been no interim sexual exposures, whether there has been treatment failure. So in this case, we would make sure that we obtain the appropriate specimens, cultures for antimicrobial susceptibility. Obtaining cultures and gnats would be recommended at the same time. And then you want to make sure that you treat with a different regimen, potentially, in this case, gentamicin 240 milligrams IM along with azithromycin 2 grams PO might be a way to go. And then doing your test of cure towards the 14-day mark. Liberally involving your infectious disease consultants in this case would also be a great idea, and make sure that local reporting occurs so individuals know at the CDC and your local public health department what you're dealing with. Next slide. NGU. So NGU is one of those conditions where we are very fortunate in some instances to have the use of our point of care diagnostics. So in this case, having access to even a first voided urine spun and seeing that greater than 10 whites, along with having your gram stain and seeing your PMNs is going to help you in your diagnosis. The 2021 guidelines highlight a change in that cutoff point where you are given some additional guidance on if you are in an STI clinic setting, presumed to be of higher morbidity versus in a lower prevalence setting, and looking at 2 versus 5 as your cutoff point in those instances. New pathogens are discussed. Definitely regimens for NGU point towards chlamydia treatment, and they are designed for that. But we know that there are other pathogens that are concerning as well. And these include Mycoplasma genitalium, which we have talked about briefly already. And then others that are mentioned, including Neisseria meningitidis, which can colonize mucosal surfaces and cause urethritis and can be transmitted by oral sex. The challenge here is that the colony appearance, in addition to the gram stain, cannot be interpreted cannot be distinguished from Neisseria gonorrhea. So you might want to use your gnat in those instances to help you tease that out. That said, you should know that the treatment regimens are going to be the exact same regimens that you're going to use for treatment of Neisseria gonorrhea infections. So you have nothing to worry about with that regard. Haemophilus infections have also been mentioned, specifically with oral sex exposure and the tendency towards resistant infections at that site. And then other reminders, you can also have viral illnesses that contribute to urethritis, adenovirus, for instance, where you can have dysuria, you can have hiatal inflammation and conjunctivitis as well. And then despite our great diagnostics and our comprehensive examination, in 50% of cases, we're still not going to figure it out. So there we go. So that's NGU. Next slide. Chlamydia. We talked about that briefly already, and in the interest of time, I'm going to move through this a lot faster. So routine oral pharyngeal screening for chlamydia is not recommended, but at many of your sites, you probably have co-partnered gonorrhea and chlamydia testing. If you do observe it, you have a positive test, go ahead and treat it. Rectal testing should be performed in populations where there is a risk for infection at those sites. And also consider performing screening in individuals based on behavior. One group to consider is women, and you might do that with a shared clinical decision making strategy where you talk to them about their risks and the available evidence to determine what is the optimal screening site for them during that evaluation. Next slide. So we have moved to using doxycycline as the preferred treatment for chlamydia infection. And this data shown here is looking at a randomized controlled trial where they looked at azithromycin versus doxycycline and did find doxycycline to make it out on top, showing that cure rate was definitely better with the use of this antimicrobial. Other data has also supported this change in recommendation, including studies from Kung et al., as well as Duke-Myers, where they have noticed that improved efficacy with treatment of doxycycline for infections, particularly at the rectal site, has been occurring. This efficacy can be smaller at the urogenital site and definitely more impressive at the rectal site. So again, taking into account risk and behavior is going to be important in determining the optimal treatment. Next slide. That gets us to partner management, and this should always be a part of whatever you do. EPT is a harm reduction strategy, and it's one that you can use when you are unable to get that partner in, or the partner is unlikely to come in for an evaluation. The regimens that will be used here would be ceftriaxone if we're concerned about gonorrhea infections, and doxycycline if we're concerned about chlamydial infections. Again, using a shared decision model may be useful, particularly when it comes to MSM, where there is less data supporting the use of these oral regimens. Next slide. So in the mashup of doxycycline versus azithromycin, this is what we're landing at. Doxy is definitely going to come out on top, and I recommend that you consider using it, with the exception of specific instances as listed here. Next slide. Mycoplasma genitalium. As we talked about it, it occurs in many parts of the United States. Next slide. And we should definitely consider it in certain STI syndromes. There is currently an FDA-approved assay that's available, and currently resistant guided treatment is recommended. Next slide. And this is taking into account not only the morbidity that we're seeing with our pathogen, but also resistance patterns, as we discussed earlier. We're talking about in 1 in 4 men with urethritis, as you can see represented in the sites across the United States. Next slide. So the current resistance guided treatment, it comes out from data from our Australian group, where they actually studied this really nicely. And they have been using resistance guidance treatment going back to 2016. And in their population, in the population study, they went ahead and used doxy to knock down the load of Mycoplasma genitalium initially. And that was found to be very effective. And this was followed by they did resistance testing to macrolides. And based on that data, they determined whether they were going to use moxifloxacin or azithromycin for treatment. And essentially, when looking at that data, the cure rate was about 95% when you have a macrolide sensitive infection, and about 92% when not, in using moxifloxacin as your regimen. With the macrolide regimens, macrolide resistance was uncommon afterwards, hence our current recommendations. We're going to go with doxy first to knock down the load, and then in the absence of actually having that resistance assay, you're probably going to go with moxifloxacin. That's all I have. I'd like to hand it over to Dr. Joesph Cherabie for our next set of slides with vaginitis. Thank you.
Thank you so much, Dr. McNeil. And so I get to speak to you all about vaginitis first and foremost. And so first, to start off, we'll speak a little bit about bacterial vaginosis. As we know, bacterial vaginosis is caused by a dysbiosis in the vaginal flora, usually caused by a decrease in the lactobacillus species with increase in anaerobes such as Gardnerella, Mobiluncus, and Prevotella species. Several bacterial vaginosis point of care tests are available these days, including nucleic acid amplification tests that are increasingly being utilized. However, many of us are still pretty old school and still will use the wet prep as well as a whiff test to and Amsel's criteria to help diagnose bacterial vaginosis. But these point of care tests are available, and we wanted to make sure to highlight that. There is no current change within the recommended treatment of individuals who could or could not be pregnant. However, there are changes in the alternative therapy with, especially for non-pregnant persons, with options being secnidazole as well as metronidazole 1.3% vaginal gel and Candice 2% vaginal cream. Of note, there is no data currently linking nitroimidazoles and alcohol adverse effects. So whereas previously we were warning individuals who were taking metronidazole that they may have an adverse effect, especially if they drink alcohol, new studies have actually shown that this is not necessarily the case. Next slide. As for Trichomonas vaginalis, currently how to test, there are 3 options available to you: wet mount, antigen, and nucleic acid amplification test, as well as culture. But culture is really helpful, especially if we are looking for resistance. So if you have cases of Trichomonas vaginalis that have been treated multiple times in the past with recommended treatment regimens, you may want to perform a culture to make sure that that Trichomonas vaginalis is susceptible to the treatment that you have been given. There is a change in the recommended treatment, which is metronidazole 500 milligrams orally BID for 7 days, whereas previously we were trying that 2 grams orally once. That was given for individuals who were HIV negative, especially in women. However, due to the study that you see on the right, you can see that actually a 7-day versus single dose, the 7-day being that green bar versus single dose being that orange bar, that the rates of Trichomonas after treatment, or individuals of the rate of failure of treatment is lower in that 7-day group compared to that single dose group. And that's why the recommendation has changed to that 500 milligrams orally BID for 7 days is in women. The alternative treatment is tinidazole 2 grams orally once. And then the treatment for men is, the recommended treatment is metronidazole 2 grams orally once with that alternative tinidazole 2 grams orally once. So not much change in the treatment of men. However, once again, in the treatment of women, we move to the orally BID for 7 days. Next slide. Now for vulvovaginal candidiasis, once again, diagnosis is mainly through KOH microscopy, culture, and PCR testing for yeast. The culture as well as the PCR testing for yeast is especially useful in cases of non-albicans candida. And so if ever you have the case of vulvovaginal candidiasis after treatment in which you are seeing the patient come back come back with symptoms, then you may want to consider Candida albicans. You may want to consider culture as well as susceptibility testing and possible PCR for non-albicans candida. As mentioned, the Candida albicans azole resistance is becoming more common, and non-albicans candida is sometimes intrinsically resistant towards azoles. For uncomplicated vulvovaginal candidiasis, you want to treat for 1 to 3 days. As for complicated, you want to treat from 7 to 14 days. Recurrent vulvovaginal candidiasis, which is defined as greater than or equal to 3 episodes per year, which of note causes a large economic burden, you want to evaluate for secondary causes. And once again, that is where that PCR testing as well as culture may be useful, with initial therapy followed by fluconazole weekly for around 6 months if it's recurrent. Of note, fluconazole use in pregnancy, there has been increasing evidence of congenital abnormalities. And so in individuals who can be pregnant, so only topical azole therapies, which should be applied for 7 days, are recommended for use amongst pregnant women. And it has been linked to an increased rate in spontaneous abortion. Next slide, please. Now, as for pelvic inflammatory disease, there has been no new information to refine acute PID diagnosis. However, there is a change in the recommended treatment. So whereas previously we were using ceftriaxone or cefoxitin plus doxycycline, now we are adding metronidazole, 500 milligrams POBID for around 2 weeks. This is for the recommended intramuscular or oral, as well as the recommended parenteral. And the reason why we are using this is because we have noticed that there have been increasing rates of anaerobes actually that have been found within PID diagnosis. And then of note as well, the option to use clindamycin plus gentamicin has been removed from the recommended or alternative treatments. Next slide, please. So the reason for this recommendation change is due to this trial, which was the ACE trial, which was a double-blind placebo-controlled trial of 233 cisgender females. And the outcome was symptomatic improvement at 3 days in presence of anaerobic organisms in the endometrium. And those were the outcomes that were being measured. The findings at day 30 post-treatment with metronidazole versus placebo was we noticed that there was a significant reduction in endometrial anaerobes, that pelvic tenderness was less common. There's decreased cervical Mycoplasma genitalium and similar adverse events between the two groups. So with that in mind, metronidazole should be used as a component of PID management. Next slide. Next, we're going to move to discussing diseases characterized by genital, anal, or perianal ulcers. The most common ones that we discuss are genital herpes as well as syphilis. And then the less common ones being chancroid, which is uncommon in the US, which usually causes a non-sexual cutaneous ulcer presentation, and granuloma inguinale, which is uncommon globally, otherwise commonly known as donovanosis. Of note with respect to the treatment of granuloma inguinale is the removal of ciprofloxacin as an alternative agent of treatment and removal of aminoglycoside as a potential treatment option. Next slide. So as for updates to genital herpes guidelines, with respect to diagnosis, detection of the previous guidelines said that detection of HSV from genital ulcers or mucocutaneous lesions using PCR or viral culture were recommended. However, currently we are moving more towards specifically the HSV PCR as the preferred diagnostic test. And so the FDA has cleared PCR-based HSV tests because they are sensitive and specific and can distinguish HSV1 from HSV2. Viral culture does have its use though. It does have low sensitivity, especially for recurrent lesions and in healing lesions. The other thing is that it's very hard to yield sometimes viral cultures. I've sent many viral cultures from my clinic before and it's quite difficult. However, it is the only way to detect acyclovir resistance HSV. So this is useful and it can be used. But once again, the best way to detect HSV is from active lesions in which you would want to unroof one of the lesions and try to get an HSV PCR specifically from that lesion, with the yield being lower, especially if those lesions are healed over. Next slide. So what about serologic tests? So the guidelines currently are allowing for a two-step serologic testing, and it is useful in very particular circumstances. Number one is for recurrent or atypical genital symptoms or lesions with a negative HSV PCR or culture result. A clinical diagnosis of genital herpes without laboratory confirmation, let's say one of your, the lesions had healed over, for example. But ideally, you want it 12 weeks after a suspected recent acquisition. And the reason why is because the yield will increase and the specificity specifically of the serologic testing that is being performed increases after that 12-week point. Also, it can be useful if a patient's partner has genital herpes in order to see if the partner that doesn't have yet a diagnosis could have genital herpes as well. So that two-step serologic testing is an EIA test. It's of IgG, and I'm going to highlight the IgG here, not the IgM. But of note, it is often falsely positive at low index values. The specificity drops down from 57.4% down to 39.8% with lower values. And so a second method of testing is required as a confirmatory test. That step 2 test is to could be a BioKit or a Western blot test. But the important point here is you want to use a different antigen than the test that was used in the EIA testing. So this 2-step serologic testing will help to determine and to help confirm the HSV diagnosis. Again, though, it might be useful in persons of higher risk of infection who have a history of possible symptoms of HSV. And this is where history taking comes in handy here, asking about those painful genital lesions and any recurrence of those symptoms. And so this might be useful for screening for those individuals who are presenting for STI evaluation with 10 or more lifetime partners, or persons with HIV as well. It is not useful for screening in the general population, and of note, IgM is not recommended for serologic testing. Next slide. As for counseling guidance, symptomatic HSV2 counseling wants the counseling for symptomatic HSV2 genital herpes, asymptomatic HSV2 genital herpes, and HSV1 genital herpes is clearly is elaborated on in the guidelines. Of course, a lot of the counseling is focused on what the natural course of the disease is, as well as some focus on asymptomatic viral shedding, which is most frequent within the first 12 months of acquiring HSV2, as well as the effectiveness of daily suppressive antiviral therapy in preventing symptomatic recurrent episodes, which can go up to 70 to 80% effective in preventing recurrent HSV, as well as to check in yearly to make sure that individuals want to stay on HSV suppressive therapy. As for asymptomatic HSV2 genital herpes, of course, in these scenarios, what we would want to make sure is you want to describe the clinical course in case this is a serological diagnosis without any kind of clinical diagnosis. And so what you would want to make sure to do in that scenario is explain to the individual what the symptoms look like, but also know that the actual effectiveness of suppressive therapy in these asymptomatic HSV2 genital herpes has not properly been studied, and there has been no studies to show actual effectiveness of that. As for HSV1 genital herpes, it is becoming more common. However, it is less likely to have recurrence, and therefore suppressive therapy is not being recommended for HSV1 genital herpes. As for HSV hepatitis, this is rare but serious, and there's an increasing prevalence of this occurring, especially amongst pregnant women. So there should be a high index of suspicion in pregnant women with fever and an unexplained severe hepatitis with an elevated ALT and AST. But also of note, they might not have lesions. So this should be a high index of suspicion. And in these scenarios, you want to make sure to do HSV testing, oftentimes HSV PCR on the blood. So as for prevention, for individuals with HIV and HSV, the risk for genital ulcer disease increases within the first 6 months after starting antiretroviral therapy, especially if the CD4 count is less than 200 cells per millimeter squared cubed. And so the of note, with immune reconstitution, you may have increased recurrence of HSV. However, antiviral therapy reduces this risk and should be continued for around 6 months after ART when the risk for GUD actually returns to baseline levels. Next slide. Quickly on syphilis. This is, next slide. This is just examples of multiple different presentations of syphilis. As you can see, these are Schenkers. Next slide. However, there are new studies that are showing that there are differences in the presentation of primary syphilis. So whereas we have previously been classically told that the syphilis presents as a single painless ulcer or chancre at the site of infection, studies are actually showing that that we are seeing more and more atypical presentations with multiple chancres that might be painful. Up to 49.2% of cases in one study had painful ulcers, as well as multiple ulcers in 37.7% of cases, and that it was infrequently associated with HSV at 2.7%. So whereas previously we were demarcating, if it's a painless ulcer, it's most likely syphilis, whereas if it's a painful ulcer, it is most likely HSV. More and more we are seeing these atypical presentations. Next slide. As for enhanced clinical descriptions of ocular and otic syphilis, these are more clearly stated within the guidelines. So for ocular syphilis, it often presents as panuveitis and can involve any structure in the anterior or posterior segment of the eye, including any of the ones listed below. Of note, it will cause redness in the eye, so you really need to, and can cause permanent vision loss. So this is one of the reversible causes of permanent vision loss, so you need to do a full neuro review of systems, including vision exam on individuals, not a visual exam. I'm just saying you want to do a review of systems of people's vision. As for otic syphilis or otosyphilis, you want to, this can cause cochleovestibular symptoms, tinnitus, vertigo, sensorineural hearing loss, and can also result in permanent hearing loss. Next slide. There is no real change in the traditional or reverse algorithms, but they are clearly stated within the guidelines. Next slide. And there's no new data on treatment. However, there's a phase 4 comparative trial of benzathine pen-G for the treatment of early syphilis in subjects with or without HIV infection, which you can look out for. As for alternative regimens, ceftriaxone is one of the alternative regimens listed. However, there is insufficient data on amoxicillin plus probenecid. A change in the guidelines, though, is that there is note of inadequate serologic response after treatment. And this is typically associated with lower titers of around 1 to 4, older age, or later stages of syphilis. So one to consider a treatment failure would be 12 months after treatment for primary, secondary, or early latent syphilis, and then 24 months after treatment for late latent or unknown duration, as well as for individuals who have HIV. Next slide. Also, in the guidelines, there is a recommendation for fewer lumbar punctures. So for neurosyphilis, there is no need for a repeat CSF examination at 6 months with an adequate RPR response. And this is for HIV negative and HIV positive individuals on ART. For isolated ocular symptoms with no cranial nerve dysfunction, CSF exam is not necessary. As well as for otic syphilis, CSF exam may not be necessary. But once again, if there is any signs of cranial nerve malfunction, or if there is any signs of altered mental status or meningismus, then you want to make sure to do a CSF examination in those scenarios. Next slide. For penicillin allergy, there are no proven alternatives for neurosyphilis, congenital syphilis, or syphilis in pregnancy. Again, you want to get a really good penicillin allergy history. And so you want to make sure to use the best treatment that is available for you, which would be penicillin in these things. And there are updates on penicillin skin testing, ceftriaxone, and oral challenge, as well as a modified desensitization protocols. Next slide. And I hand off to Dr. Hilary Reno.
Hi, everyone. We're going to wrap up with a brief coverage of some of the other aspects of the treatment guidelines and how they have changed. So first, let's talk about HPV. The treatment guidelines have been updated to include the up-to-date information on vaccination. As we know, HPV is our most common STI. It can cause genital warts as well as pre-cancer cancerous lesions from primarily the type 16 and 18, but also a number of other types of HPV. And for that reason, there's a 9-valent vaccine. This vaccine has been recently approved for those under 46 years old, though insurance coverage certainly is varied for that upper age groups. But the ACIP recommendations focus on all adolescents being vaccinated at ages 11 or 12 with a 2-dose schedule. So if they are initiated on HPV vaccine prior to being 15 years old, 2 doses is adequate. If they initiate vaccination after 15 years, 3 doses is needed, or also if they are immune compromised. So HPV prevention and these updated vaccine recommendations are noted in the treatment guidelines. Next slide, please. So the treatment by and large for genital warts has not changed from the 2015 guidelines. And you can see the general recommended regimens for external anogenital warts listed here. There are additional boxes that include specific notes for treatment of warts around the urethral meatus, vaginal warts, or interanal warts, and those are new. And so the key there is that some of these regimens for extragenital warts are not recommended for these more internally located warts. There also is a section about the management in people who may be pregnant or have HIV when it comes to wart management. Next slide, please. As far as screening, the guidelines have been updated and are in line with the other organizations that issue HPV screening recommendations. So for persons with the cervix at average risk, initiating screening at 21 years old is recommended, and that should continue through 65. Screening should be every 3 years if it is cytology alone, and by using cytology alone in those in their 20s, and then every 3 years if cytology alone is used for those over 30. If HPV co-testing is used for those over 30, then screening can be spaced out to every 5 years. For people over 30, as I have mentioned, screening can include these FDA cleared tests for those high risk oncogenic types of HPV, and that will allow for screening to be spaced out more. What is new and unique to the guidelines is that they contain extensive new tables on screening and surveillance recommendations that pulls all major guideline group recommendations together in one place. And so I find that very helpful to be able to look at all of those together on one table. Next slide. This is a screenshot of that table 1, and you can see you have the US PSTF recommendations, ACOG, and ACS recommendations all on the same table. This is also applied to how to handle testing results when they were and screening results when they return. And so it's a really great one-stop shop to understand more about HPV screening and management. Next slide, please. So when it comes to HPV and its involvement in other types of cancers, and we know cervical cancer results in about 13,000 cases in the US. This was the case in 2019, and a little over 4,000 deaths from cervical cancer. But also of concern is anal cancer. And so anal cancer screening and management is an area in which more data and understanding is needed, but there is some new information in the 2021 guidelines to bring us up to speed. Digital rectal exam is noted that could be useful in detecting anal masses in people with HIV and possibly cisgender men who have sex with cisgender men without HIV. This is actually from the HIV Opportunistic Infection Guidelines and the International Anal Neoplasia Society. The STI treatment guidelines also note that anal cytology is not recommended for anal cancer screening, and HPV tests are not clinically useful for anal cancer screening with the lack of trial information there. There are ongoing trials, and when those results are released, analyzed and released, then it's possible that some of these recommendations could change. But currently the current data on anal cytology is reviewed in this section, as is the management of anal squamous dysplasia is briefly discussed. And again, these future studies can help inform guidance in the future. Next slide, please. In regards to the hepatitises, for hepatitis A, there are very few changes, just that there is a table that's been updated with the recommended vaccine regimens, including the combined Hep A, Hep B vaccine, which wasn't included before, and a summary of the ACIP recommendations for Hep A vaccination. There are also some updated parameters listed for post-exposure prophylaxis with immune globulin for Hep A, and the categories have been updated. Next paragraph, the next slide. This box reflects the ACIP recommendations for populations recommended for Hep A vaccine. So again, this kind of highlights how there are aspects of the guidelines that help it serve as a really nice reference for those of us that like to have these at hand. Next slide, please. In hepatitis A, there's a continued recommendation that vaccination be offered for people seeking STI care at STI clinics or in other clinical settings. The pre-vaccination serologic testing has been updated to note these three aspects of Hep B: the Hep B surface antigen, anti-Hep B surface, and total anti-Hep B core. For people with hepatitis B infection, they should be tested for other STIs. Next slide, please. For hepatitis C, there is a new section on hepatitis C in the 2015 guidelines. It was listed as an emerging issue, but as we know, the past 5 years have seen changes in hepatitis C in leaps and bounds. So the guidelines, though not the definitive source for hepatitis C information, include updated epidemiology of hepatitis C and HIV co-infection and some additional information on its transmission biology. It also references the updated screening guidelines from the CDC that all adults over 18 should be screened during their lifetime, and that pregnant people should be screened during pregnancy except where the prevalence is less than 0.1%. And then routine screening is recommended for people with ongoing risk factors. There is some additional discussion of hepatitis C screening in pregnancy, and those treatment is not this part of the scope of these guidelines. And we all know that it is, now we have effective treatment, so there's lots of information out there, and those resource links are included in the guidelines. Next slide, please. In regards to the management of victims of sexual assault, there is some additional information in the 2021 guidelines discussing the exam and testing for cisgender men who have sex with cisgender men, sexual assault survivors. And that is very important information in management and assistance for these patients. There's also updated tables that incorporate the treatment changes that have been noted in other aspects of the treatment guidelines that are relevant when it comes to the prophylactic treatment of STIs here, including, of course, ceftriaxone 500 milligrams IM dose being noted as a recommended regimen, plus the doxycycline and flagellas as needed. Next slide, please. When you go to the beginning of the treatment guidelines, they're kicked off by a discussion of prevention methods. And so this includes a new 5 Ps, and that is augmented by this new guide to taking a sexual history, which is available on the CDC Division of STD Prevention website. The new 5 Ps are noted, and this toolkit is noted to be more patient-centered, using gender-affirming language, and so should be of help for people that are trying to learn how to take a sexual history or want to brush up on how to do that. There is also a review of the literature on prevention counseling, including new information on the success that has been shown with shorter interventions and some really innovative web-based programs. Language has been updated, not just STD becoming STI, but also the recognition that external and internal condoms are improved language over past language that's been used. There's also a new section on multi-purpose technologies. So it's not a very big section, but this is an emerging area in the field. And so there is some discussion of what exists. Primarily when someone asks what a multi-purpose technology would be, I would point out the internal vaginal rings that have been evaluated to deliver both birth control as well as PrEP as an example of a multi-purpose technology. There's also more current, a review of the current data on STI PrEP and PEP. This would be the taking of medication, usually doxycycline, in anticipation of preventing syphilis or gonorrhea in certain patients. This is also an evolving area in the field, and I would anticipate there being additional information from studies emerging very quickly, probably. Next slide, please. So in regards to the management of sex partners, there is a partner service section in the beginning of the guidelines. And so This really just reiterates some very important points that evaluating all sex partners is needed, that when it especially comes to gonorrhea and chlamydia, presumptively treating all partners within 60 days, and the use of expedited partner therapy is recommended. There is an additional guidance that you can consider, shared clinical decision-making around expedited partner therapy for cisgender men who have sex with cisgender men, and that it's important to presumptively treat the most recent partner, even if that last contact was over 60 days. And then next slide, please. When it comes to expedited partner therapy, we've mentioned this already. So this is just a summary slide noting that expedited partner therapy for gonorrhea is to use ceftriaxone 800 milligrams orally once, and chlamydia co-infection, if it is present or has not been excluded, then there is the decision between doxycycline course and the azithromycin course. When it comes to chlamydia, expedited partner therapy is preferred in those that would not be pregnant to be doxycycline a 7-day course. And then for those that could be pregnant, azithromycin a 1-gram course. Now we do and are aware that this is somewhat difficult and challenging in many different ways to implement. And so you will find programs approaching this in many different ways. And remember, your prevention training center can help you navigate that and the implementation of aspects of the guidelines in your clinical system. Next slide, please. So briefly and finally, a review of special populations that are mentioned in the guidelines, and this includes pregnant people, adolescents, cisgender men who have sex with cisgender men. There is an expanded section on cisgender women who have sex with cisgender women and women who have sex with women and men, as well as a very much more informative section on transgender and gender diverse people and their sexual health, and sections on persons in correctional facilities and for those with HIV. Next slide, please. Just a note, when it comes to pregnant people, there was a change in the serologic screening recommendations based on community prevalence and risk factors for those people that warrant serologic screening in the 3rd trimester. That was made more specific by saying 28 weeks would be an optimal time to do that, and then also at delivery. Why was this? There was an understanding that at 28 weeks, additional serologic blood work is done, glucose tolerance testing, and this would be conveniently offer additional syphilis screening opportunities there. Now, the decision of when to screen pregnant people for syphilis, the 3rd 28 weeks and delivery, is based, as I said, on a number of community prevalence and risk factor issues. And these risk factors have been a little bit updated because we know more about the emerging cases and increases in congenital syphilis and some of the factors that go into that, including an acknowledgement that if someone is late to prenatal care or has no prenatal care, is unhoused, and there's a misuse of drugs, that these could contribute to an increased concern for congenital syphilis and warrants additional serologic screening in pregnancy if it's not already mandated by state legislation. And the risk of infection is certainly based on ongoing behaviors. And so that for someone who has, for example, a new sex partner, that screening, additional screening in pregnancy could be warranted. Next slide, please. In regards to STI screening in adolescents, they really recommendations really remain unchanged, although there's some additions, including the discussion of permissive testing for rectal screening since cisgender females based on reported behaviors, and recommended rectal and pharyngeal screening in young cisgender men who have sex with cisgender men. And then there's some additional information on resources on PrEP recommendations in adolescents. Next slide, please. For cisgender men who have sex with men, there's continued emphasis on the importance of taking a sexual history and providing really tailored counseling, testing, and care, as well as a review of PrEP as it stands now, and a new section discussing the data on PEP and PrEP for STIs, where we know that further studies are expected and additional data is anticipated. And then a section also on enteric organisms as STIs that Dr. McNeil hit on in her section. Next slide, please. And then just to wrap up, as I said, there's new sections here for WSW and transgender and gender diverse people, including an expanded discussion of how to orient care to be gender affirming and follow good sexual health principles. And that for transgender and gender diverse people, screening really should follow that gender-based recommendations based on anatomy. But the key there is to be aware of potential for a history of trauma in the medical system and to employ trauma-informed care principles to offer good care for these populations. Next slide, please. So if you have questions, we have a general email available there for you. And I'm going to hand it back to Allison, I think. Thank you.
Thank you, Dr. Reno, and also Dr. Cherabie and Dr. McNeil. So great, we are going to move on to a question and answer session. And so we've had some really great questions come in. And I just want to remind everyone who's listening, if you do have more questions, we will try and get to them. Please use the Q&A button that's on the bottom tab. And then in the chat, there's also an email where you can send your questions in case we don't get to them. And this will go to CDC. The email is stitxguidelines@cdc.gov. So just wanted to put that out there. So I just wanted to start with a question for Dr. McNeil. A question came in. For chlamydia treatment with doxy versus azithromycin, there's been a lot of back and forth over the years about whether or not adherence to doxy is worse than suboptimal treatment with the one dose of azithro. What evidence made the change back to favoring doxycycline?
That's a great question, and I'm sorry we didn't get a chance to go into it in too much detail. But there are several trials that were taken into account that have looked at the performance of doxycycline, specifically at the rectal site, and looking at how doxy definitely outperforms azithromycin when it comes to effectiveness in curing infections at that site. That is definitely leading data that has helped make that recommendation. When it comes to certain populations, you definitely have to have that conversation about, where are you having sex? What sites are exposed? Because there may be some individuals where, their risk for a rectal infection is lower than others, and their likelihood of non-adherence is higher. And in those individuals, that would lead you probably along the lines of azithromycin, but definitely it's a collaborative conversation that needs to happen in order for you to make that decision.
Great, thank you. Dr. Cherabie, I have a question or two for you. These kind of go together. The first one is, what do you recommend regarding testing men for trichomonas?
So that's a very good question and quite difficult. There's a lot of the testing modalities that we used or that have been cleared for the FDA have actually only been cleared for women. And for either cervical samples, endocervical samples, vaginal samples, as well as urine samples. There is a small list of FDA approved tests for male urinary samples, and those are listed clearly on the guidelines as well, if anyone is interested in that. But typically you would want a urine sample, which would be a PCR. So that is available. And then the guidelines do clearly list out, especially when to consider trichomonas in men. So of course, if the male is a sexual partner to a female who has been recently tested positive for trichomonas, then they should receive probably treatment as they have had sexual contact with that individual. But also, if you have certain situations of cisgender men who have sex with cisgender women, and this is a case of persistent urethritis, that is non-gonococcal urethritis, then you should probably consider trichomonas and possibly even empiric treatment for trichomonas in those scenarios, simply because it is a cause of non-gonococcal urethritis within this population, and it should be something that is looked at.
Great, thank you. I have a bit of a follow-up. It's another question. It's what is the treatment for female sexual partners of Trichomonas vaginalis? And I really love this question because now we have testing for men, and the guidelines kind of are a little softer on EPT for trick. So I'm wondering if you can kind of wrap that up. So it doesn't really talk about specifically female partners of men who've been diagnosed with trick. That's kind of an inverse of what we've done historically. So could you talk about that? What's the touch on EPT and then treatment for female partners of folks diagnosed with trick?
So saying that the guidelines are soft on trichomonas EPT is quite accurate, actually. So we've had many discussions, Dr. Reno and I specifically about this topic. But with testing that has been available for cisgender men, for example, then of course you would want the partner to be treated. There is no study that has shown superiority of one dose over the other. So ideally you would at least want 2 grams once. It is the more, it would be the easier dosage to give. Of course, it's a one-time dose as opposed to taking twice a day for 1 week. So an answer that I typically give would be 2 grams once, but again, there are no studies to show superiority of one over the other, especially in the case of expedited partner therapy or partner therapy services.
Okay, thank you. So Dr. Reno, I have a question for you. It's about HPV. And if a person was previously vaccinated with Gardasil 4, is there a benefit to vaccination with the Gardasil 9?
So that's the difference between the 2 vaccines is that Gardasil 9, which is the one that's available in the US, includes an additional, I have to do my math, 5 serotypes of HPV that are responsible for about another 20% potentially of the cervical cancers. We know that 16 and 18 are responsible for about 70% of the concerned lesions and cancers. And then the other 30% is made up of other serotypes. And so for an additional 20% is potentially covered by the other 5 serotypes in the vaccine. And so first of all, there are no guided studies on this. We do not know how much of an extra benefit it is. We do know that people acquire HPV pretty soon after sexual debut. And there's no way to determine if you've been exposed and have acquired 1 strain or 6 strains. And so really there is the quick guideline-based answer is that there's no guidance there. Okay. I think that I have often had this discussion with patients, and some patients opt to receive Gardasil 9 and some do not. That's really based on their risk, on their concern about risk. But again, there's no science to guide us, and there's no, though there may be a theoretical discussion you can have, there's no way that you can do testing and use evidence to help make that decision.
Okay, thank you. I did want to share a comment someone had put in. It's not a question, but if anyone has anything to add, please do. But a participant had mentioned that some insurances may not cover the HPV vaccine in office as an immunization for adult patients, but will cover it via pharmacy as a prescribed medication when it's administered by the pharmacist. And they just shared that was the case for them as a 40-year-old trying to get the vaccine. Have you guys found that for your patients as well?
I found such a variety in coverage that, and honestly, I work in a Ryan White clinic or in public health, where most of my patients either don't have insurance or have Ryan White based coverage in this case. And so navigating private insurance, those patients, I've asked them to call their insurance and check before they're vaccinated to check on those details.
Okay, great. Thank you. So back to Dr. McNeil, we do have some questions that came in around MGen and then some of the syndromes. So I'm just going to start with one about cervicitis. For cervicitis, you mentioned several organisms in addition to gonorrhea and chlamydia should be tested for, like herpes, MGen, trichomonas. Could you just talk a little bit more about that, the recommended treatment for those organisms?
Sure. Yeah,
I'm
so
not sure what the
for gonorrhea and chlamydia, there are different ways that you can do it. Self-collected specimens is definitely something to consider in individuals who are coming through your clinic. People do a great job of collecting their own specimens, and anatomically they can get it just right. So that's an option versus provider collected at the vaginal or cervical site. And so that covers our gonorrhea and chlamydia. When we're talking about herpes, you want to make sure you have a lesion that's present that you're swabbing for PCR testing. A blind swab of the vagina would not be useful in this case for diagnosis. And so that's when I would use your HSV testing, would be if you had a lesion at any anal genital site. Trichomonas vaginalis, we had a very great talk by Dr. Cherabie. I don't think I need to chirp on that. Except just to remind people that as providers, we are great diagnosticians, but in looking under the microscope, we can miss about 50% of cases. So some places have protocols where they do reflex testing, where they go from a wet prep to a NAT, versus some places will do a NAT because they know about the poor performance of our eyes in detecting trick. So that's something to keep in mind. I should also mention there are great point of care diagnostics, of which there's a great list on the FDA website if you're curious about that. Mycoplasma genitalium, I think that was one of your other questions. There is a current FDA approved assay that's available that can be used, but I would use it specifically for individuals who are having persistent cervicitis. I think that would be the niche for that particular testing. And then, of course, make sure everybody gets HIV and syphilis testing as a part of their comprehensive STI care.
Great, thank you. I want to touch on syphilis for a moment, Dr. Cherabie, and there's a couple of questions that came in. One is asking about painful syphilis lesions, and I think you had mentioned just kind of non-traditional or non-classical presentations. And so people are wondering, what's the rate of incidence of this? Why has this changed? I guess my question would be, has it changed? Can you talk to that a little bit more?
Yeah, of course. So I think we are all seeing a lot more syphilis these days than we had previously been seeing. And the rates of syphilis from the surveillance from the CDC has also shown that. So we are seeing a lot more individuals presenting with a variety of different presentations of syphilis. Now, the reason why a syphilis lesion may be painful is because it could be superimposed infection by something else, such as Staph aureus, such as HSV as well. So there are multiple different reasons why a syphilis lesion may be painful. But the study, and it is included within the reference is included within the slides if anyone is interested, but there was a study that did show that the rate of the painful chancres is actually, it can get up to 50%. And so, and then you can have multiple lesions as well. So again, these are open chancres that are area of fluid and all of that stuff that is a perfect medium for a superimposed infection. So that might be something that you want to consider. And so I've seen a lot more atypical presentations of syphilis. I mean, when we look at syphilis that is taught to us in the textbooks, painless chancre, primary syphilis. Secondary syphilis, it's that palmar and the rash on the palms and soles of the feet. However, the majority of my secondary syphilis patients are presenting with a rash on their abdomen, for example. So we go over this quite commonly, especially in our clinical settings. I try to teach a lot of my residents this, but there is a lot of with the more syphilis that we are seeing more atypical presentations of it. And so I think it is called the great imitator for a reason. It can cause a lot of different things. And so I think it's just something to keep in the back of your mind. And if anyone is presenting with a rash, before you send them to dermatology, you may want to get a an RPR, especially if they're sexually active and get a good sexual history as well.
Great, thank you. I'd like to go back to MGen and just open this up to anyone. I think a lot of us have questions about MGen. It just seems like such a gray area. So I'm combining a few participants' questions, but it's really about, would you recommend routine testing for MGen? And then what about partner treatment for MGen and test of cure or follow-up? Can you kind of walk us through that? I just open that up to anyone. We may all have different ways we're managing it.
I can chip in. I see Dr. Reno mouthing Dr. McNeil over there. So MGen is definitely one of those emerged pathogens. It's out there and we are having great challenges with managing it, but we have some guidance that's there in the CDC guidelines that you can reference that'll help you out in a few areas. For one, Mycoplasma genitalium testing, it's still not one of those routine testing areas for the multiple syndromes that we've discussed thus far. And it mainly shows up when we're talking about our persistent infections, our persistent syndromes, the ones of which we've discussed, including, we discussed urethritis, we discussed cervicitis. It makes an appearance in proctitis, it makes an appearance in PID. So mainly in those infections where we're not getting a clear answer, this is a test you'd want to consider. You asked another question about partner management. I think that was one of them. So partner management, we know that concordance is pretty high. You have MGen, there's a good chance your partner could have MGen. And in terms of management, well, if you had a test available to you, getting a test done might be an acceptable strategy. If you don't have a test available to you, you can consider using a treatment regimen that would work on MGen. And that section is in the guidelines in the partner follow-up section. There is another instance where we talked about test of cure. I believe that was a part of one of your questions. In terms of test of cure, it is not recommended, but there is a unique scenario I did want to mention that I didn't go into in too much detail. When we're talking about the two-step process of treating an MGen infection. So starting with doxy to knock it down, and then either using moxie or azithromycin as your treatment. If you are using azithromycin, and we know that we don't have a resistance assay that's available broadly in the United States. So if you're using azithromycin and we know that there is a strong tendency towards resistance with macrolides, then that is actually one of those unique instances where you would consider doing a test of cure. And so the guidelines talk about doing a test of cure at about 21 days in those individuals. Did I miss another sub-question?
No, I think you got it. I'm going to follow up because someone else also asked about the treatment, if there's any data for MGen treatment with dual therapy. So I think they mean at the same time. I'm with doxy and moxie for 7 days total. Because I think the regimen was you did one to knock it down and then you followed it, but is anyone looking at dual therapy together?
I would like to thank that provider for that excellent question. So the challenge here is we have a shortfall of antimicrobials that can treat MGen. It's an area that's being studied. In the United States, we have probably less of that antimicrobial armamentarium that we can use. One that we do have available to us in the United States is minocycline, where there are some limited studies regarding its effectiveness for resistant infections. But I will put in a plug for our infectious disease doctors in this case. If you are at that point where you're trying to decide whether to throw on moxie and doxy at the same time and you are challenged with that infection, you probably need to phone a friend, and I would recommend putting in a consult to the NNPTC. We actually have some experts in MGen across the country that would love to help out with that question.
And there will be a registry for difficult to manage MGen infections that is forthcoming that will help inform us. Right.
Great. Dr. Reno, so we have just a few more minutes, and I'm hoping we can squeeze in one or two more questions. This one's for you, Dr. Reno. It's about recommendations for anal PAPs. So what are the recommendations for anal PAPs for persons living with HIV?
Right, so we've gone through a lot of different phases here, right? So we were doing anal paps for a while, but the clinical implication and management issues were pretty big. Really, right now, the recommendation is that digital rectal exams annually are preferred. Anal paps are still done in locations that have access to endoscopy and have specialized people to address any findings from those anal paps. I will say here in St. Louis, we do not have access to those a specialist right now, and so digital rectal exams annually are what we are using. But I know that differs throughout the country. So we don't have the definitive study results that we would want at this point. And Candice, you might know a little bit more about how some other centers are managing.
Thank you for the punt there. But I'm going to agree with you in that we are still waiting for that wonderful large study that's going on that's looking at how best to manage individuals while trying to prevent anal cancer. So I'm going to agree with your answer there. And you need to have access to anoscopy services and then high resolution anoscopy and also treatment if you're going to be doing anal paps. And that is a really, it's a huge hurdle to get over, especially in certain practice settings.
Great, thank you. All right, let's see if we can, oh, it's 12:29. I think we probably should wrap up. I just want to say thank you to all of our speakers today. And also thank you to our audience for your great questions. I know we didn't get to all of them. There were a few more I was hoping we could get to, but please enter them into the email that was just put in the chat. So it's the STI-TX guidelines at cdc.gov, and you can get an answer to your questions. I do want to remind you all, we have one more national STI treatment guidelines webinar coming up on September 22nd. And I think we put the registration in the chat. So please copy that, share it with colleagues who maybe weren't able to attend today, or if you felt like you weren't able to catch the whole thing, come back. We are presenting the same information at each webinar, just trying to reach all time zones across the US. Destiny, do you have anything else you'd like to add?
And thank you so much for attending and for your thoughtful questions. And as always, if you have a tough STI question, you can always ask it at stdccn.org. And one of these lovely experts will be able to answer you in 1 to 5 days. Thank you so much for your participation.
Thank you.
Thank you. Bye-bye.